Es así, ¿no, Die?
Sí. Ahí va entrando la gente.
No está Ebonie, estoy chusmeando acá, pero no.
Ven ahí están los participantes, a ver si está Ebonie
Sí.
acá.
Yo la estoy chusmeando, pero no está. En la E no está.
Le mando el número de... ¿Vos, Estela, pudiste entrar bien con el número de...?
There's Ebonie. That's Ebonie.
Ebonie.
Hi, you have to mute.
I think I'm gonna have to unmute her.
Yes. Hi, Ebonie.
Hello. I'm so sorry I'm late. I was having trouble with the link.
No,
Okay,
perfect, no problem. How are you?
I'm so well.
Sorry.
How is everybody?
Fine.
Fine. Really glad to meet
Very,
you
very good.
after
Lovely
several
to meet-
emails.
I know. Thank you so much for the invitation.
No,
thank you for being
accepting.
here.
Fantastic. I'm just going to remove my husband's washing from behind me. Just one second.
Okay.
Now that is better.
Perfect,
Yeah,
perfect.
perfect.
So you're gonna have to be at the English channel. Is that okay?
Yes?
Perfect. Okay. Yeah. Yeah, you go to Spanish. I'm gonna stay in the English because I'm gonna be talking to Ebonie.
I'm gonna stay in Spanish.
Okay, you, Pablo, will be in Spanish, and you, Max, will be at English?
English, yes.
Okay, perfect. I think we have 66. Yeah. Okay, perfect. Claudia, ¿vos me escuchás? So, wait a second.
Escucho perfecto, Claudia.
Claudia, cuando vos estés haciendo la interpretación, Estela va a estar muteada, ¿ok? Eso es lo que me dijo que te diga. Ok, yo me paso al inglés otra vez. Ok, that's it. Perfect. We are with 66 participants, so we will wait 2 more minutes. Is that okay, Ebonie?
Of course. Of course.
Yeah, perfect.
Perfect.
Okay. 65.
So, Ebonie, this is your first time you have been interviewed by Argentinian people?
Yes?
Okay.
I was so excited to be asked. Thank you very much.
Oh.
Have you been in Argentina, Ebonie?
No, I have not. It's on my wish list. So hopefully, once everything is back to normal, I might be able to come and visit.
Yeah.
Yeah.
That would be awesome.
Excellent.
Okay, 69. What do you think, guys? We should,
we should start. I think
should we
you
start,
have to tell people about the interpreter, the channel, and everything, and we should start.
Okay, perfect. Well, I'm gonna put in the Spanish channel for a little bit so I can tell everybody how to use it. Bueno, buenas noches a todos. Bienvenidos al webinar con Ebonie Rio. Calculo que todos la conocen. Este webinar va a tener la característica de que va a tener una interpretación simultánea al español, con lo cual ustedes van a poder decidir si quieren escuchar el canal en español, que van a escuchar a las intérpretes, o si quieren escuchar el canal de inglés, donde van a escuchar directamente a Ebonie. Si escuchan el canal de español, lo que van a hacer es escuchar de fondo la voz de Ebonie y en un primer plano la voz de la intérprete. Yo voy a hacer las preguntas en inglés como para tener un diálogo con Ebonie y después lo que vamos a hacer es contestar las preguntas que ustedes puedan ir haciendo. Hay un icono que ustedes tienen abajo donde dice interpretación. Ustedes cliqueando ahí en el icono de interpretación van a poder elegir si quieren escuchar en español o en inglés. Si ustedes lo tienen apagado, creo que van a escuchar el audio original únicamente, pero elijan inglés o español, ¿bien? Y al lado de ese icono van a tener un icono que dice preguntas y respuestas. En ese icono ustedes van a poder colocar las preguntas que uno de nosotros va a ir seleccionando y al final de la entrevista vamos a tener un tiempito como para poder hacer las preguntas que ustedes quieran, ¿bien? Cualquier consulta que nos quieran hacer, pueden hacerla a través de ese icono de preguntas y respuestas, cualquier cosa, ¿sí? Okay, I'm gonna go to the English channel now. Perfect. Wait a second. That's it. Okay. Now the official welcome. Ebonie, first of all, I want to thank you for being here with us. We are thrilled to have the opportunity of listening to you today.
Thank you so much. I'm delighted to be invited.
Perfect. For those who don't know, Ebonie works at La Trobe University with Jill and many other professors we will be having the chance of listening to next month at the Tendinopathy Symposium she will be part of. I really want to know, how is your day-to-day at La Trobe University? Do you usually see patients or mainly research or teaching?
I choose to still see patients. So I am mainly a researcher, but I love being a physiotherapist. And I think my research is better because I still see patients. And so I do research that I hope has an impact in the clinic.
Oh, perfect. And you see mainly tendinopathies or you see everything that's sports related?
Interestingly, I see everything that's sports related. I have a tendon clinic that I run with Jill, but we see a lot of people that have been misdiagnosed. And I also work at our Victorian Institute of Sport where I see any of the athletes. So I still see lots of different conditions, which again, I really like.
Okay, perfect. So maybe you know, some weeks ago, Jill answered some of our questions about tendon pathology, assessments, and some rehab. So she answered all of our questions. So now we are going to talk about low back pain. Is that okay? No, that's a joke. The idea of this interview is to talk about the role of neuroscience in tendinopathies. And at the end of the interview, I will ask you, is that okay with you, some questions from the audience? Is that okay?
Of course, of course.
Perfect. So, starting with some Q&A to warm up. About biomechanical risk factors, there are always some controversy regarding them and their association to tendinopathies. What are your thoughts on this topic?
That's an excellent question. I think the differences that we see in research where we see some association and then no association is because there's so much individual variability. So in the clinic, we might see someone that has had a different injury, say an ACL reconstruction on the other side, and so they have a calf deficit, and all of those individual factors influence what we see and how we manage somebody. So the research isn't convincing that there are strong biomechanical factors for tendinopathy in the way there is for conditions like patellofemoral joint. So the patellofemoral injury is much more associated with, knee valgus and hip control, and that association hasn't been shown in tendinopathy. But what I will say is we do see changes in biomechanics that we're starting to understand, such as things like movement variability. So people with patellar tendon pathology don't have as much movement variability in the way they land, which might predispose them to sort of overloading in one set pattern.
Okay, so is there some biomechanical risk factor that you specially assess in, for example, a patellar tendinopathy, or just, I don't know, landing and that kind of things?
Yeah, in the initial assessment, no, because I think it's really difficult to differentiate pain and muscle dysfunction with biomechanics. And so what I'm really looking to do in the initial assessment is gather the information about their current function. So I might look at their function, but not specifically from a biomechanics perspective. It's more, I do look at how much they're prepared to bend their knee in a hop or a landing movement. And the reason for that is that actually really helps me with diagnoses. People with patellar tendinopathy don't want to use their patellar tendon like a spring. They're very stiff, whereas people with patellofemoral joint can often be quite spongy and quite soft, and you see a lot of valgus. So even looking at someone hop can help you differentiate those. But I'm much more interested in their capacity. So I'll assess pain and function, and then down the track, once we've established that, consider whether or not we need to really focus on biomechanics. But everybody does it differently. You could ask different clinicians and they would give a different answer.
Perfect. Thank you. That's a nice answer. So moving to compressive load, we know managing compressive load is key in the rehabilitation of most tendinopathies, maybe not all, but most of them. So supposing you avoid compression at the beginning of the rehab in a, for example, insertional Achilles tendinopathy, because it was really irritable or the reason you want to choose. When do you start allowing compression again during the rehabilitation?
That's a really tough question, but it's an excellent question. So there are so many factors that you might consider, and the first one might be how irritable it is. So for the person with insertional Achilles tendinopathy that can't even stand in bare feet, we would get them right out of compression with a very high shoe for quite a long time. And we would slowly bring them down, and we wouldn't do that early on. We would start with the slow tensile loads out of compression, and we would avoid compression for a longer period of time. But for the less irritable insertion, I would introduce it much sooner. You also might have to consider different demands, like if they're a hockey athlete or there's someone that actually needs to get into those compressive loads a little bit earlier, some of our taekwondo athletes. And if you've got competitions coming up, you might introduce those loads earlier than you would otherwise plan. But the key thing is, as you pointed out, because it's so provocative, you need to change one thing at a time. So if that's something that you're introducing, keeping everything else the same so that you can really make sure the tendon gets adapted to it.
Perfect. Thank you. Thank you so much. I think all of us here agree that in case of a tendinopathy, we need to strengthen the tendon. We need to load the tendon progressively. And that we have to address function also, not just keep the head on the loading. Is that it, in your opinion, or do you think we are missing something important with this approach?
I think we should be open to the fact that we might be missing something with this approach. I think that the best evidence is absolutely for loading. I think we all need to be evidence-based, but that's never recipe-driven. And the reason for that is there's never going to be one exercise, is the answer isometrics? Is the answer eccentrics? Of course it's not, because the way we use our muscles and the way we use our bodies need all of those contraction types. So we need to use the evidence of strength training in tendons and heavy slow resistance, but we need to be much more thoughtful, because we also know in people with tendinopathy that they usually have an asymmetry. So to apply a recipe from research that is double leg is not something that I do. So I use heavy slow resistance training. I use concentric, eccentric, isometric, but single leg. And then following on from that, we also know that people have deficits in the rest of their kinetic chain. So we can't just do, you know, an isotonic leg extension for patellar tendinopathy and forget about the calf. That would be madness. But in research, that's sort of what we have to do because we try and answer quite specific questions. But to lead into your excellent question, I think we have to consider that because tendons are so challenging to treat, there could be things that we're missing in and around changes to our central nervous system. So there could be changes at the spinal cord level, there could be changes at the brain level. And so it's not saying that we have to throw out everything we do. How can we enhance what we do by starting to understand some of those neuroscience concepts?
Perfect. That was the answer I was looking for.
Oh, good.
So how can we recruit the motor cortex with exercises?
Excellent. So there's actually a number of different strategies. So I'll describe a few that have been reported in neuroscience because it's nice to have options as clinicians. So one of the ways that we can change our motor cortex is by doing a skill. So when you do something that's very skillful, you get lots of plasticity. So you get changes in your motor cortex. And I want everyone to just remember how your motor cortex works. And it works essentially like a car where you have excitability and you have inhibition. And so the excitability is like your accelerator and your inhibition is like your brake. And everything that you do is a balance between that accelerator and that brake, whether it's a fine motor skill or a gross motor skill. The reason why that's important is we've demonstrated in patellar tendinopathy that there are changes to both the accelerator and the brake. And there's also some fantastic research in the elbow and in the shoulder to show that there are also changes. So the physiotherapist in me looked at the data and said, well, perhaps my excellent rehabilitation is not doing enough to address the motor cortex. And maybe that's why tendinopathy is very persistent. We can often see it on the other side. Even after we've completed a rehabilitation program, we know that people can have problems for many years. So to answer the question around techniques to address the motor cortex, it needs to be skill-based. So a skill can be something like you copying what I do on screen. So you might copy the exact movement that I do for the speed, for the range of motion. I'm giving you parameters. I'm giving you visual information that you're focusing on about how quickly I'm moving, how much range I'm moving through, and you're working very hard in your brain, and that will actually induce plasticity in your motor cortex. So we can use our visual system. Another system is to use our auditory system. And the reason why I chose this in research is I felt that we could apply it to, we could merge it with best practice exercise. Because what we can't do is say, oh, well, it's all about the brain. We clearly still need function and strength and capacity, as you said, of the muscle and the tendon and the kinetic chain. So the auditory system works on making a movement skilled by giving constraints around the movement. So to give you an example, for something like the patellar tendon, the leg extension machine, we would cue someone to doing 3-second concentric and 4-second eccentric, and they would have the sound of the metronome to pace the movement, but they're actually not responding to the sound. Your brain preempts that rhythm. And what you do, it's fantastic. What you do is your brain goes, wow, I've got 7 seconds to complete this skill. So even though you are doing strength training and you will get fantastic strength gains, you also induce this wonderful plasticity in your brain because you're forcing your brain to make that movement skillful. How did you go with that, interpreter? I'm so sorry. That was quite big. Well done.
That was awesome. So that was really nice to hear live the accelerator and the brake explanation. I heard it so many times in webinars and everything that hearing live was nice. So you mentioned pacing from the outside as a way to address motor cortex, and you mentioned visual and you mentioned auditory pacing. Is there a difference between them? Is one of them better than the other?
Oh, that's a great question. In terms of the research, if we're just considering plasticity, then the research would say one is not better than the other, that they all have capacity. The challenge that we have is that much of the research in the metronome, much of the research that we have using visual input has been completed in populations with neurological conditions such as Parkinson's. So it's quite difficult to apply that to musculoskeletal research, whereas strength training research has been using the metronome for a long time. And so there's just much more research in that space. But we are looking at doing some research where we're combining both of those tools, actually, because you would hypothesize that will be effective. I would hypothesize that will be effective. So I'll let you know.
We'll see. Yeah. So this metronome, this outside pacing, at what stage of the rehab do you use it? Just at the beginning or through the whole rehabilitation? And I ask you some more questions so I don't interrupt you later. Do you use it in isometrics, isotonics, both? Do you use it in analytic or kinetic chain approaches, exercises? I think that's all I have.
So at this point in time, with our understanding, we use it quite early on. And the reason for that is there is much research to show that if you externally pace very good runners, you actually make them run worse. So I was mindful of changing the skill in athletes, that they actually have this this self-driven skill that they need to do. So we use it early on because that's our best understanding at the moment. But if we do this again in a year, that might change. We might have more knowledge, but we use it early on in the isometric and the isotonic phase. And the reason I used it in the isometric phase was to make sure that the stimulus in my study was the same as the stimulus in the isotonic group. But so it wasn't just listening to the metronome for 45 seconds, it was maintaining attention to the task. That's the critical thing. So it might be, okay, you know, lift your leg up to 45 degrees and hold, and while they've got the metronome playing, set encouragement every 10 seconds to say, fantastic, keep it steady, focus on the muscle, just to really again engage almost mindfulness during strength training. And so we use it in isometric, we use it in isotonic. But interestingly, the Australian Ballet Company, who are wonderful, they've started using the metronome in some of the faster movements. So if you have someone with Achilles tendinopathy, they might do the metronome 2 seconds up, 3 seconds down for their calf work. But then a progression for them might be going up and down a flight of stairs, keeping the heel off. And they might start quite slow, so 60 beats per minute, but then increase the speed. Because what you can do is increase that metronome up to the sort of speeds that they need to do for class, like Petit Allegro. So I think that's a wonderful example where they do use the external information actually as part of their skill. And so there's likely to be an application for them more than perhaps our volleyballers or our basketball players. But at the moment we use it early on.
Okay, perfect. So you mentioned that speed of 60 is, I read it earlier that 60 was like the magic number, no? It's like where everybody goes. But now you mentioned that you can speed up the rhythm. It's just to do a specific task that you have to speed up, or I mean, with a general patient, it's 60.
Yep. So the reason why I chose 60 beats per minute is that's actually the frequency that engages both sides of your brain. So every decision that I made in that study, every single decision was based on something. So the 3-second concentric and the 4-second eccentric, that was based on the fact that if you have a slightly longer eccentric phase, you need to engage your frontal lobe for planning. So everything about that study was evidence-based from lots of different research. When we're doing strength training, it's very important that we do it slowly. The biggest challenge for our tendons is asking it to act like a spring. So when we're doing our spring loads and our faster loads, it's always body weight only, because that's what adds load to a tendon, that high tensile load that Jill would have described really nicely. So if we're doing work in the gym, keep it slow and keep it based on your 60 beats per minute. If you'd like to use a metronome, don't add additional weight, no weights fest. But if you're starting to do some spring work, it can just be body weight only. And I would encourage clinicians to have a go and to see what works for them. Every single patient that we see is an N of 1 research project where we're testing something, we're treating, we're retesting. And as clinicians, that's what we do every single day. And in research, we're often much more constrained, but clinically, that's exactly what we need to do.
Perfect. That was a nice answer.
Thank you.
So I know you have a mobile app that's called Rehabilitendon, and I don't know if is that available for iOS or just for Android, because I can manage to find it.
We're in the very final stages of release, and I feel like I've been saying that for a long time. I can't believe how much work is involved with releasing an app. So just for complete disclosure, when it is available to purchase, you know, I plan on buying some fabulous pair of shoes or hopefully an Audi. So just so everyone knows, you know, that I'm talking about something that I would get money for, just to be very clear. But also to be clear, we did the app to try and help patients and clinicians because everybody's busy. So the research of applying the metronome or visual cues, it's not that easy for us to go away and do that for every patient. So the motivation behind the app was to actually try and bring some neuroscience into the clinic in a way that was very easy for people. We changed the original app from being just tendon to actually being anterior knee pain. So you can use it for people that have patellofemoral joint pain because it will help you change the loads that you'll use, because often they can't tolerate heavy leg extension. So it has lots of sneaky neuroscience in there actually. So in the beginning, you enter some basic information about what language you speak, your skin color, you know, ethnicity, so that what you see and what you listen to is as close to self as possible. So I would have an Australian English, because we have a funny accent. So I would have Australian English, Caucasian, you know, female. And we're hoping to get it translated into different languages, because we actually all listen at a set frequency based on our native tongue. So I wanted the auditory, even the instructions, to feed into this neuroscience, as well as the metronome, as well as the visual input.
That's brilliant.
We'll see. I hope so.
Okay.
I'm excited.
Yeah, I know so. I know so.
That's the study. That's what I was talking about before. We're going to use that app in research and have a look at the effect of combining the visual and the auditory information to see if it has an effect.
Yeah, perfect. Okay, so moving on to isometrics. What do you think is the main purpose of isometrics to you? Decreasing pain or loading the tendon, or both?
Yeah, fantastic. I think it's important that our clinicians, it's important that we have options. So I think what isometrics gives us is a fantastic option for early loading. I think a lot of people are fearful of loading. They're fearful of pain. So in combination with excellent education around tendons, it gives us an option for early loading. I think for some people, for athletes, for example, the pain relief is very attractive. I think for a lot of people, it's the confidence of being able to do something that does make them feel better, that they can do themselves. It's very empowering. And it provides, for me, the importance for isometrics is it gives us a way in. It gives us a start point that we can really engage people with exercise. It's very difficult. So the original research for eccentric exercise is fantastic, because it really demonstrated how important load is. The challenge, if something is painful to complete, is the adherence. So where we need to not
Sí, que es un segundito que creemos que ha tenido un problema de conexión, Ebonie.
No sabía si había sido yo.
No, es Ebonie.
Ok, bueno, vamos a esperar un segundo entonces. A ver.
Hello, I'm sorry, my internet dropped out. Apologies.
No problem, no problem. So we were talking about isometrics, okay? You were saying that it gives us a starting point for those people that we cannot load in high, or it's like first level of loading, no? So regarding isometrics, do you think every tendinopathy should respond to isometrics, or we could find some that don't respond, but the tendon is still the source of the pain?
Really good question. I think that in many of our tendons, there is a lot of mixed presentations. So I think that, for example, in something like the patellar tendon, we have a very narrow definition of who we would call tendinopathy. And the challenge is that not everyone might agree, and that's okay. But I think if we don't agree on how to diagnose the condition, that produces a lot of uncertainty for clinicians. So we would consider someone with, very localized inferior pole pain with load that does not move or spread, so no referral at all, and that they're aggravated by conditions where you ask them to do a really fast movement, like a spring type movement. So therefore, by definition, the converse of that is that isometrics and isotonics are a very safe load that won't provoke them. So I think it's really important that we all think about how we diagnose tendinopathy. And if you diagnose tendinopathy in terms of its rate of loading, then by that definition, isometrics and isotonics are a safe start point. But remembering that humans are very complex. And so if I said to someone with fear and tendon pain, oh, this might hurt you, we'll give it a try. You know, I would not be confident that they would respond well. So I think our non-specific treatment cues are very important. And then when you consider other regions like the Achilles is very complex. You can have peritendon involvement, you can irritate your sural nerve, you can have a superficial bursa that's irritated, you can have plantaris. So our group of people that we would say that respond to isometrics and isotonics positively are a subgroup of those. So if we consider all of those to be under the same diagnostic criteria, then yes, not everybody will respond. That's very important. For example, I used to tell people to try isometrics for peritendinitis. That's a disaster. Don't do it. I take that back. I'm so sorry, everybody. It makes them worse. So that's really important. Clinically, if someone isn't responding or they're getting worse, then we can debate the diagnoses. For me, that's not important. The most important thing is, how does that change our management? What will we do next? If we can't even start with a static load, what are our options for that person? And for knee pain, it might be something like the blood flow restriction. There's some fantastic research in that. For something like the Achilles, if you're considering the peritendon, it might be that you need some treatment for that sheath before you can do any loading. So the most important thing for me, research and clinically, is if someone is, if it's a safe start load and they're no worse or they're better, fantastic. I would start with that load. If they're worse, how does that change what I need to do?
Perfect. So far, the best answer to that question. So we're going to give you a prize later.
Oh, thanks. A trip to Argentina.
Yeah. Imagine I had some patients in the past, mainly with lateral elbow tendinopathy. For me, the worst tendinopathy in the whole body. That are really, really irritable at the point of not even bearing isometrics. Okay? I know if I ask this to Sheil, she will say, okay, then it's not the tendon. So I'm going to ask you, let's suppose it is the tendon. How do you approach that patient? Will you load him anyway with soft isometrics? Will you wait and see? Will you use passive treatments for a while? I want to know your opinion, your way to do it.
Excellent. I'm going to answer you as a clinician because I don't have any published research in the elbow. So there's much better elbow researchers to ask. So this is my clinical opinion.
Gotcha.
So the first thing is that I really consider what their provocative load is. So the people that sit on keyboards and do lots of low load repetition need to be managed quite differently to the people that do the spring type loads. And I think the confusing thing is often in research they're put together, but clinically they respond very differently. I would use passive treatment that enabled me to find a start point of load. I would use lower loads if that's what they tolerated. I would, make sure I was treating the neck or the radial nerve or just any other contributor because they, again, can often coexist, as you know. I would use techniques such as cross-education. So I would load the other side as heavy as I could, and I'd educate the patient as to why are we going to do that. And so I would get as many of these small wins together as I could. If they found that a brace helped, fantastic. If they liked heat, brilliant. If some soft tissue work through their elbow allowed me to build a good relationship and some trust with that patient and to find a way to get them to load, then that's what I would do.
Perfect, perfect. So I'm really glad you mentioned the cross education, because it was my next question. How do you prescribe that cross education? Do you give them isometrics, isotonics, light, heavy? What do you do with them?
So I don't ever give isometrics for cross education. I use isotonics. So and importantly, the research in cross education tells us that if it's heavy, you get better cross education. So I try and load heavy, and actually, if you use external pacing, cross education is augmented, so that it's improved with external pacing. So the way I would explain it to my patients, because education is key, the way I would explain it is that we actually want you to be symmetrical, but we want you to be symmetrical at the end of your rehabilitation and not at the start. And actually, if we strength train your non-tendinopathy side, it'll actually drag your other side up quicker. And I use this post Achilles rupture. I use this with patellofemoral pain, knee joint replacements, anyone that I see. It's a fantastic clinical tool to be able to load the other side and get some genuine strength gains on the side where they might be very sore and you might be really struggling to see improvements.
Okay, perfect. So that's it for me. I'm more than satisfied with your answers and your clarity. So I'm gonna ask you now some questions from the audience.
Excellent. I'm gonna fill up my coffee.
Perfect. Go ahead. So Pablo asked, can you tell us your story with isometrics in a tendinopathy patient? What did you think about it that make you do that first research? So what's your starting point with isometrics? When did you imagine that, well, let's try with isometrics?
Excellent. So full credit needs to go to Jill Cook and Craig Purdom, because the idea around starting isometrics is entirely credited to them and their fantastic brain. And what they started with was reverse engineering. If doing something very quickly for a tendon and asking it to act like a spring is provocative, then we can't start with those loads. But we also know that complete rest is not helpful. In fact, it's detrimental. And so because we know that load and capacity are so closely related, we need to find a way to start to load. And so Jill and Craig started using isometrics clinically, and I was working up at the Australian Institute of Sport at the time, and Craig Purdom was my boss, and I was still very, very good friends with Jill, so we kept these conversations going. Jill had some fantastic success with an Australian football player in terms of pain relief, where nothing else had been helpful. And so, you know, the patient where you get a big win that really sticks in your mind. And it's true for clinicians and researchers, that really sticks in your mind. So I approached it from a research perspective, wondering, are we just warming the tendon up? And that's why I compared it to isotonics. And that's why I spent so long piloting the protocol to make sure that they were the same for the time under tension, for the rating of perceived exertion, for all of the visual and auditory cues, so that they were entirely matched. Because I wondered, was it just because you were doing something?
Yeah.
You know, is it just warming them up? So if I just looked at just isometrics and people improved, then I couldn't answer that question. So I compared isometrics and isotonics. And then I thought, well, I'm asking people about pain. And I you know, if I'm very enthusiastic about something, I could actually influence their answer. So what I need to do is write a script of what the researcher will say so that it's the same for both groups, so that they both have the same expectation that this is a safe load. But I'm not sitting there going to them, oh, this one will really help you, and we're not sure about this one, because that's so important in pain research, and that's often overlooked in research, but it's very important. So I had a script of expectation for the participants. And then what I wanted to do was say, well, how could I use this? How could I use this as a clinician? So now I need to measure things like their strength. And I was interested in their inhibition. I was interested in the brain. But I was interested in strength because if I did isometrics or isotonics and they felt better, but then they had poor capacity and they were weak and they went and got another injury, I wouldn't be very popular with the coach or the athlete. So the design of the first study, in terms of looking at the immediate effect, was very much, how could I use this? I don't want people to take that research and say, oh, everyone must do isometrics and you've got to, you know, do it this many times a day. The purpose of that research was, what information do we have so that we can use it clinically? Well, we know that isometrics and isotonics were both very safe. They both reduced pain. Isometrics had a more profound immediate effect, and it reduced the inhibition, which means I could use it right before a game of football with confidence. And that's very important in terms of the implementation, is really understanding the effect of it. So even though it was heavy, because it reduced that break, they and that excess inhibition, they were able to access their strength. So lots of credit to Jill and Craig.
Perfect. So I've noticed that you mentioned several times the contextual factors within the clinical parts of the tendinopathy rehabilitation. Do you pay lots of attention on those contextual factors in your day-to-day clinic?
Yeah, I think we have to. I think my understanding of pain has improved greatly. I think in my initial research, I thought it was just down to my, you know, fantastic intervention, you know, the specific exercise and how I designed it. And I think I didn't pay enough attention to the way I had designed the study and the script and the language. And I think that's important clinically, because we need to understand that we have so much influence over people's pain and people's understanding of their condition, and that's actually very empowering. But I think early on I was misguided in thinking that it was just the load. And, you know, Jill, again, has taught me so much. She has spent her career doing fantastic education. And I think she doesn't even appreciate how important that's been. It's profound for a patient. We spend most of our time talking in our consults.
Perfect. I love it. So another question from the audience regarding your research. What do you think? Oh, this is a simple but tough one. What do you think is the source of pain in the tendon?
Oh my gosh, how long have you got? It's a really good question, and I get asked this a lot. We know a lot about what it isn't, and it's important to understand that, because again, we can really empower our patients. So we know that it's not traditional inflammation. There are inflammatory mediators in there, but their clinical role is not clear. So the danger is calling it tendinitis, because people's underlying understanding of what they need to do for that condition is rest ice anti-inflammatories. And we know that that's not effective. So our language in using tendinopathy is very important. I say to people, we call it tendinopathy because no one knows what that means. So we can tell them it means they need to exercise. But if they think that it's inflammatory, if you ask any of your family members what to do for an inflamed tendon, they're not going to answer with exercise. So the biology is so important, and our language is so important, again, around those contextual factors to promote adherence and all of those things. We know that, or we've previously thought that it might have been the neovascularization, but now we know that we can see those changes in completely asymptomatic tendons. So we know it's not neovessels. We've previously, there's been lots of potential candidates over the years, but none of them so far explain the clinical picture, and it has to explain why people with this presentation have pain, and then you don't see it in people with no pain. So it isn't just changes in the tendon, because we know that asymptomatic pathology is really common. If you're very nerdy like me, I wrote a paper with colleagues. It was the first paper of my PhD actually on tendon pain. So the pathophysiological and physiological aspects. And we proposed that it was actually changes to ion channels, which are the little receptors on nerves that get stimulated with either movement or changes in the biochemical environment, or both in this case. And it gives information up through the spinal cord and to the brain. So that would be the driver. So my not so brief answer would be that I think we see these development of ion channels in tendons, because it explains things like the warm-up factor, because these ion channels get saturated, so they get full after a few minutes. So that's important, because our nociceptive driver has to be able to make sense clinically.
Perfect. So I think we have time for one more question, at least from the audience. And that's, well, you mentioned that you didn't do any research in lateral elbow tendinopathy, but one of the questions is, how do you differentiate, at least clinically, between lateral elbow tendinopathy and radial channel syndrome?
Oh, wow. That's a toughie. The upper limb nerve tension tests are a very important component of the assessment, as well as actually looking at the elbow joint. The patient history is important in terms of what positions and what activities provoke them. If we're thinking lateral elbow tendinopathy, so not the low load repetition, but more the load based, then I would be looking for features like the warm-up phenomenon, being worse the next day, that their pain is quite localized and provoked with higher load. Interestingly, because of the cam of the radius, they're actually more provoked in supination than pronation. So even just some of our manual tests can help us. But it really is putting together the whole picture. Some of the radial nerve presentations can have not only some referral, but some of the pins and needles and some of those neural symptoms as well. So putting together the whole picture.
Perfect.
No more elbow questions.
No, that's it. Okay, I think that's more than enough that we could ask you. And I want to know, finally, what are the research that you are working on now?
I have so many cool projects at the moment. One of them, I'm using virtual reality, and I'm using virtual reality. So it's sneaky neuroscience. I'm changing how much you perceive you're moving. So I'm changing your visual gain compared to the real world, so that I can target pain, for osteoarthritis pain. So people that can't, get in and out of a chair. So we're actually getting them to load by getting them to move in ways that they can't in the real world. So that's super fun. We're doing some great research in hamstring recurrent hamstring strains. So I'm looking at the brake and the accelerator, because again, hamstring recurrence is a big problem. And we have fantastic rehabilitation. So again, are we missing something? Back to your original question, you know, are we missing something in the way we're doing this for the people that just keep straining their hamstring on return to play? I'm going to do the study with the visual and auditory cueing for the patellar tendinopathy. I've got a great study about to start in the Achilles, looking at how we differentially diagnose by applying load. Because I think that's the key thing clinically. If we give everybody an intervention, we'd like to know who is likely to do well and who isn't. I don't want to read another study that says more research is needed because some people got better, some people got worse, and some people were the same. It does my head in. I want much more information about responders and what are the features of them so that we can apply it clinically.
Okay.
So that's
perfect.
a few.
Yeah, that's a lot. So Ebonie, I cannot thank you enough for doing this tonight for us, this morning for you. And I think I speak from all of us that you are really nice people. The way you talk and you explain things is really clear. So it's really an honor to listen to you and to have you on board on the tendinopathy symposium. So thank you again.
Thank you so much. That was really fun. I hope we can do it again. And yeah, I look forward to the tendon symposium. It's going to be exciting. You've got a great lineup. I look forward to hearing the other speakers.
Yeah, perfect. Well, thank you. Thank you all. Gracias a todos por estar acá. Gracias a las intérpretes. Thank you to the interpreters. Y gracias a todos los que se sumaron a este evento.
Thanks everybody for coming.
Thank you, Ebonie.
Thank you.
Thank
Thanks
you,
so
Ebonie.
much.
Thank you. Bye,
Thanks,
Ebonie.
everyone.
Thank you
All the
very
best.
Bye,
much.
everyone. Thank you.
Bye-bye.
We'll talk soon.
Bye.
Bye. Thanks.